as you know, I work in Beaujon Hospital. In the department, we do only HPB surgery. We do between 150 and 300 liver resection, the same number of pancreatic resection, and between 110 and 120 liver transplantation. For laparoscopic pancreatic surgery, I will talk mainly about our experience. We published recently our large experience of pancreatic surgery in Europe, and of course about some literature data. We started our experience in the laparoscopic pancreatic surgery in 2008, and now about we perform 25% of our pancreatic resection are done by the laparoscopic approach. But of course it depends, we know that the rate depends on the experience of the surgeon, because many surgeons, even if there is some indication, they do not do the pancreatic resection, but about 25% are done by the laparoscopic approach. We now experience about more than 400 pancreatic resection. Of course, the first indication was for distal pancreatectomy. We have nearly 100 pancreatic pancreatectomy, many cases of central pancreatectomy, and of course we have some in inclusion. The three main indications in our experience are non-invasive IPMN, adenocarcinoma, and neuroendocrine tumors. If we look to the applicability rate, if we compare between the laparoscopic and open approach, if we have experience in laparoscopic surgery and open surgery, in my experience, nearly 90% of distal pancreatectomy can be done by the laparoscopic approach. About 30% of football can be done by the laparoscopic approach. All central pancreatectomy are done by the laparoscopic approach, and 50% of indication can be done by the laparoscopic approach. In my presentation, I will talk about distal pancreatectomy, pancreatic pancreatectomy, and if we have time, I will talk some slides about central pancreatectomy. For distal pancreatectomy, as I mentioned, 90% can be done by the laparoscopic approach. The relative contraindication, pancreatitis, we should be very careful in patients with chronic or acute pancreatitis, patient with large lesion and portal hypertension, of course, vascular reconstruction or digestive resection. It is a contraindication to the laparoscopic approach. And if parenchyma sparing resection is not possible by the laparoscopic approach, for me it is a contraindication to the laparoscopic approach. For the exposition for the installation, in my experience, the surgeon is to the right of the patient. We have 5 trocars, 2 trocar of 10 mm, 3 of the 5 mm. In more than 90% of cases, we cut the pancreas by stapler. In the other cases, we put some ligation. In our experience, when we operate, I don't cross the hand between the surgeon and the assistant. I think it's very important in order to operate in very good condition. For the first, I think for when we do surgery on the distal pancreas, the exposition is very important. We developed a sample technique, the hanging gastric. If we can have the video or not? No. You can click on them, please. Yes. Gastric hanging is very easy. When we cut the gastrocolic ligament, we pass a dissector on the right side of the left gastric vessels. We have the dissector. We introduce a trocar in the epigastric area. Then we turn the stomach 180 degrees along its horizontal axis. We put some gauze between the stomach and the abdomen. We remove completely the trocar, and really you have a very good exposition on the pancreatic gland. The second point, for me, it is very important to cut the pancreas before cutting the vessels, because it is a very problem. I think when we cut the pancreas first, then you can have easily the splenic vein. You cut the splenic vein first, and after you can, at the end, you cut the splenic artery, because the splenic artery, it is very deep, it is posterior. First, pancreas first, the vein is the second, and the artery at the last. For laparoscopic distal pancreatectomy, it is safe on our experience. Really, when we have experience, you can do it much more rapid by the laparoscopic approach than by the open approach. We have very rare transfusion. very rare rate of conversion. And if we look to the outcome, we don't have mortality. We have 27% of grade B and C pancreatic fistula. The hospital stay is 16 days because in France, if we have complications are managed in the hospital until complete healing, and we have very low rate of bleeding, reintervention, and readmission. Because we know that already from many studies that the laparoscopic approach does not decrease the risk of pancreatic fistula. But in our experience, really since 5 years, we changed our, previously we trained our patient with large multi-table drain. Now we put a small suction drain, and really with this small suction drain, we decrease the rate of pancreatic fistula. If we look to the subgroup patient with larger drain and small suction drain, really we have less pancreatic fistula. Of course, we have more collection, but the patient who need percutaneous drainage is the same. Only 4% need drainage. In the hospital stay, it was significantly shorter in the subgroup of patients with small suction drain. And this was the only significant factor on multivariate analysis. Really for me, when we do this type of pancreatectomy, there is no need to drain. You have more collection, but the collection disappears spontaneously few weeks after. This is an illustration. This patient has mesonosis syndrome of the distal pancreas. She had laparoscopic pancreatic resection. We have collection, no drainage, and a few weeks after they have complete disappearance of collection. Really, in our experience now, more than in 90% of cases, patients who had laparoscopic distal pancreatectomy can go home less than 7 days after surgery. Even at day 3 or 4, they can go home. What about resection for adenocarcinoma? We know that from many publications that it is safe. We have many studies comparing the laparoscopic to the open approach showing that it is safe. But we know in laparoscopic surgery, there have many biases when we compare the laparoscopic to the open approach. This is a multicentric European study. We included our patients in this study, 34 centers in 11 countries. We compared patients who underwent resection for adenocarcinoma between the laparoscopic and the open approach. And we know that patients who had resection by the laparoscopic approach, there is less resection of the gerota fascia, and the number of lymph node retrieval was lower. There is no difference in overall survival, but we don't have data on recurrence. For that, for me, if you have small pancreatic adenocarcinoma, you can do it by the laparoscopic approach. But if you have infiltrated or big lesion, I think it is still indication for the open approach. But the problem of laparoscopic pancreatectomy is not the pancreatic fistula. The pre-problem, when we look in our experience, the indication for pancreatic adenocarcinoma is less than 20% of cases. And more than 80% is for low potential malignant disease. This patient had no cancer, and this subgroup of patients we should do parenchymal spheric resection and the preservation of the splenic vessels. And we know that parenchymal spheric resection, it is much more difficult to do it by the laparoscopic approach than by the open approach. For that reason, if you cannot do it by the laparoscopic approach, in this case it is better to do it by the open approach. There is, for me, for lesion on the distal pancreas, there is at least 10 modalities of resection. You can do central pancreatectomy. For this patient can be central pancreatectomy with or without the splenic vessel, short caudal, distal pancreatectomy without the spleen, enucleation, because there is no need to remove the pancreas for small IPMN, and distal pancreatectomy with splenic. I think there is many different modalities, and we know that the surgical difficulty and the complications are completely different. For laparoscopic pancreatic duodenectomy, we know that in recent technique, really we have increased in this technique since 6 to 7 years. If you look really from it recently, we know that it demanding complex surgical procedure. 3 anastomosis are needed. We have to do some ligation, and if we want to do this operation, we have experience in both open and laparoscopic pancreatic surgery. For the surgical technique, we use the 6 trocar, 3 of 10 mm, 3 of 5 mm. In our experience, we use the pure laparoscopic approach. We do 1 layer pancreatic anastomosis because I think double anastomosis, 2 layers is much more difficult to do it. For us, the contraindication are vascular invasion, patient underwent neoadjuvant treatment, obese patient, acute or chronic pancreatitis, and if we need to section some medial arcade ligament, or if we need to do multiple frozen section like in patient with IBMN. We know that with the laparoscopic approach that we have longer operative time, at least double with the open approach. The operative time introduced with the experience. In very selected patient, we can do it in 4 to 5 years, but in my opinion, more than that, more than 6 to 7 hours, we should discuss conversion. Of course, we can have reduced last less, but we know that patients are selected. In the conversion rate, it varies depending on the series between 0 and 16%. To do briefly, for the majority of teams, the outcome was favorable, but it was less favorable in our early experience. I am the only surgeon who published negative result on the laparoscopic pancreatic-biliar. We published our series. We started our experience in 2011, and we compared 46 patients who underwent laparoscopic pancreatic-biliar to 46 who underwent the open. When we, in the 2 group, patients with the laparoscopic approach had lower body mass index, the pancreas was more softer. And when we compare laparoscopic to open, in about 1 patient, in 25% of cases, we have severe complication, grade C pancreatic fistula, bleeding, or reintervention. And the only risk factor for severe pancreatic fistula was the presence or absence of pancreatic adenocarcinoma. If we have pancreatic adenocarcinoma, we had harder pancreas, and the outcome in this case was similar or even better in the laparoscopic compared to the open approach. This patient had pancreatic adenocarcinoma, have chronic pancreatitis, main pancreatic duct dilatation. I think in this patient, the risk of complication is lower, and this patient is very good indication to the laparoscopic approach. And why you have more complication with the laparoscopic approach? Because it is a new surgical technique. Difficult anastomosis, at least in the early experience, it is difficult to do 3 anastomosis by the laparoscopic approach. Pancreatic fistula are probably more aggressive. We know that with the laparoscopic surgery, we don't have adhesions, probably you have are more aggressive. And probably selected patient at high risk of pancreatic fistula. This patient had ompyloma. There is no vascular invasion. It is an excellent indication for resection, but we know that patient with ompyloma, there is fatty infiltration, are at high risk of complication. For that reason, we have more complication with the laparoscopic approach. But since our first experience, we still do the laparoscopic pancreatic-biliar, but we do it in patients at lower risk of pancreatic fistula, no fatty infiltration of the pancreas, female and young, because we know in young and female we have less pancreatic infiltration of the pancreas. And of course, with the experience, we have better patient selection, improvement of the surgical technique. We do better our anastomosis, we do better our hemostasis, we do better our drainage. We do an early CT scan. This patient had early CT scan at post-operative day 5. There is no connection. Everything is okay. This patient, when they have connection, there is something it is wrong. In this case, we can reoperate the patient. We can do something. And of course, when we look to our last 26 cases, really we have better result. We have less bleeding, less intervention, and less hospital stay. There is many new studies in the literature. If we look to the mortality, but because it is much more easy to do with the mortality than the morbidity, there is 2 recent studies in the United States with increased mortality with the laparoscopic approach. Recent one in 2015, 5 versus 3%, and this is from Netherlands. They do about 120 cases of laparoscopic pancreatic-biliar, and the mortality rate is 6%. 6% is high. In our experience, 4%. The probably we have more complication, at least in the early experience, when we start to do laparoscopic pancreatico-biliar. We can do, in selected patients, we can do some rate of R0 resection between the laparoscopic and the open approach. Probably the lymph nodes are not optimal in all patients. If we look to the laparoscopic and open approach, there is less lymph node harvested with the laparoscopic approach, 9 in this study. This patient, I operated on this patient for distal bile duct cancer, and he presented with recurrent lymph node. Probably the lymph node was not very optimal in this patient. This is, I think, this is the open view. This is the laparoscopic view. I think in selected patient, we can do the same by laparoscopic and open approach. On the other hand, if you want to do superior mesenteric artery first approach or some vascular resection reconstruction, I think this is not possible by the laparoscopic approach. Can we have the video if you please? Really, if you have selected patient, we can do by the laparoscopic approach like in the open approach. This is the specimen is completely up to the left. This is the superior mesenteric artery. This is the superior mesenteric vein. Really, when we have selected patient, we can do it the same. This patient had right hepatic artery. We can do the same by the laparoscopic. Even a selected patient, really, even we can do better by the laparoscopic approach. The same for the lymph node, the bile duct, the hepatic artery, the portal vein. Really, we can do the lymphadenectomy the same. The portal vein, the pancreas. This is the superior mesenteric artery. You can have lymphadenectomy on the right border of the superior mesenteric artery. Really, we can, a selected patient, you can do the same. Okay, for central, we still have time. For central pancreatectomy, we know that normally it is proposed for patients with low potential malignant disease. It is very important to preserve the pancreatic function in this patient because this patient had no cancer. They will have a long-term survival. So there is no vascular and no carcinogenic contraindication. As I mentioned, in my experience, all candidate patients to central pancreatectomy are operated by the laparoscopic approach. I don't never do it by the open approach since 2011. But we know that the risk of central pancreatectomy, we have the right pancreatic remnant, we have anastomosis, we have vascular dissection, we have 2 potential sites of pancreatic fistula, and we know that the risk of complication, we can have a bleeding from this operation. In our experience, we use the pancreatico-gastric anastomosis. The installation, we have 5 trocar. The surgeon is on the right of the patient. In some team, they do pancreatico-gastric anastomosis, but we know that it is much more easy in case of central pancreatectomy to do pancreatico-gastric anastomosis because it is not like with the pancreatico-biliary. You can have that choice. In our experience, it is very rapid. We only have 1 conversion, 1 transfusion. With experience, it is much more rapid to do it by the laparoscopic approach than by the open approach. And if we look to the data, we don't have mortality, and the grade B and C pancreatic fistula is about 23%, 11% of bleeding, 8% of reintervention. Really, the results are similar or even better than those with the open approach. To conclude, laparoscopic distal pancreatectomy is safe, but parenchyma surgery is more difficult to do by laparoscopic approach. This is the problem. Laparoscopic pancreatectomy is associated with higher morbidity, and for me it should be done at least in a patient at lower risk of pancreatic fistula. With experience, we can extend the indication. For pancreatic adenocarcinoma, only limited one can be resected by the laparoscopic approach, and laparoscopic total pancreatectomy had a high applicability rate, acceptable morbidity, and we have a parental advantage because these resections are done for patients with low potential malignant disease with very excellent long-term prognosis. Thank you for your attention.